Good evening to everybody, and I'm Dr. Rabindran from Ramachandra Medical College. It is indeed a pleasure to introduce Dr. Arjun, one of our younger energetic GM candidates, uh, who is about to present his work on Journal Club, and we will be going through his presentations. And in case you are finding any doubts or repetitions, please feel free to ask, interrupt in between, and we will follow the clinical discussion followed by the critical appraisal. Dr. Arjun, please proceed with the presentation.
Yes, sir. Thank you, sir. Good evening, everyone. Today, I will be presenting the Journal Club for the IAN. So the moderator will be Dr. Rabindran sir, who is the assistant professor in our SRMC Chennai. And today's topic is assessment of infant position and timing of stylet removal to improve lumbar puncture success in neonates, preferably called as a NeoCLEAR trial. And it is an open label 2x2 factorial randomized control trial. So our learning objectives are to understand the role of infant position and timing of stylet removal in this procedure, and to discuss the statistical methods employed in this journal and the normal consort statement for critical appraisal purpose. So why it is called as a neonatal champagne lumbar puncture every time? It's the name. Previously, lumbar puncture is considered as a champagne tap, where it determines the clinician's proficiency in atraumaticity of the procedure in the getting a clear CSF fluid. So as if when we pop a champagne bottle, the color of the champagne liquid that comes out is as similar to the CSF. That's why it is called as a champagne lumbar puncture. So it was conducted in 21 UK neonatal, United Kingdom neonatal and maternal units. The journal was published in Lancet, and it is a good impact factor of 37. So Picot statement wise.
Dr. Arjun, can I interrupt?
Yes, sir.
Just for the benefit of the students, can you tell what are the measures by which we can assess the journal's quality?
Sir,
like impact factor, what are the other factors and what you mean by impact factor? What are other indexes, to assess the quality of a journal?
Sir, impact factor is to usually tells us how the validity of the journal and how much we can rely on, or the practices that were done in the journal. Usually impact factor of 10 signifies a excellent one, but the present journal article as having an impact factor of 37 is very good. So that's such.
What are other factors? Other factors apart from impact factor? Okay, this is not a prepared question session, so Dr. Arjun is a little surprised by the questions, but it is for the interest of the general. Anybody can answer. What are other methods by which we can assess the quality of a journal? In the interest of time, I will just mention it shortly in a minute. There are majorly 4 indexes. One is the impact factor, which is nothing but the average number of citations to paper published in the journal. So how to calculate impact factor is the last 2, very good, H index. Yeah. The last 2 years, for example, if you want to, very good, getting answers, it's very appreciating to know that all are participating actively. So in the, if you want to, you can raise your hand, or you want to interrupt and answer. If you want, somebody wants to answer, because it's not my lecture. Somebody else wants to answer the questions. What is H index, Dr. Sanju? For example, if only one author is good in a journal, one journal is there and one author is good, his articles alone are cited more. That means around 10 authors, one author's article is keep on getting better citation. Because of the one article, the whole journal gets a good impact factor. So to avoid that, the H index was started. H index is nothing but the number of articles, H number of articles, that is cited H times. For example, if 3 articles are cited 3 times, the H index is 3. If 10 articles are cited 10 times, the citation H index is 10. So it indicates that the journal contains a number of multiple authors who are having a good impact factor. So that is the reason that article is being read by number of people. So H number of articles, are you understanding, Arjun, Dr. Arjun?
Yes, sir.
H number of articles are cited at H times. That means 5 articles are cited at 5 times. It is called H factor of 5. For example, if articles are around, is it not audible? Is it audible, Arjun?
Audible, sir.
Yeah. So for example, if 1 article is cited 10 times, but 3 articles is cited 3 times, the H index is only 3, not 10. That is H index. And Google has got a index, I10 index and I20 index. It's very simple index. I10 is total number of published papers with at least 10 citations. For example, if Dr. Arjun puts a publication and it is cited 10 times, so Arjun got I10 index of 10. So I20 is the total number of article journals which has got a publication of 20 citation. The total number of journals in that the articles in the journal having a citation over 20 is called I20 index. And the impact factor is very simple to calculate. To identify the impact factor of Lancet 2022, I have to go to the 2020 and 2021. The number of articles published in 2021 and the number of articles published in 2020, which are cited, divided by the total number of articles published in 2020 and 2021. Are you able to understand, Arjun?
Yes, sir.
Impact factor is not for 1 year. You have to go last 2 years. You have to go to 2020 and 2021. Total number of articles which is cited divided by the total number of articles which is citatable. So that is the impact factor. H index just now discussed. I10, I20 is recently introduced for easy understanding. That is four types of impact factors. The number 1 is impact factor. Number 2 is the H index. Number 3 is I10. Number 4 is I20. Okay. So it is just a straightforward Googly. So we are not prepared for the answers. So Dr. Arjun, you can go ahead with the presentation.
Yes, sir. Thank you, sir. So the Picot statement, the population wise, they have taken babies under the corrected gestational age of 27 plus 0 to 44 plus 0 weeks of gestational age and weight more than 1000 grams. The intervention and the control groups are comparison groups are the infant positioning, that is with the sitting versus lying, compared in the format of early stylet removal, that is ESR, with LSR, that is late stylet removal. And they were compared with divided into 4 groups and compared among the groups of those. And the outcome was to see mainly the successful first LP procedure, that is a clear CSF with RBC count fewer than 10,000 millimeter in CSF, millimeter cube on cerebrospinal fluid. And the trial was conducted for a duration of August 3rd, 2018 to August 31st, 2020. Yeah, the background and rationale for beginning of this article by them research is till now there is no such current practice valid for LP techniques. There is no such evidence to document which is the best approach or which way to do or what are the protocol to be followed. It just describes that we have to take the successful LP as a clear CSF where it is not traumatic or a traumatic procedure. And it is determined by how much of the ml of sample got or the atoms we have taken and what were the risk factors or the adverse events were recorded during that procedure and what are the outcomes of that sample that helps in decreasing the use of antibiotics or the rationale behind using it. So introduction wise, as we know, neonatal period as itself has the highest risk of bacterial meningitis and it has a substantial rate of mortality or sometimes even a higher rate of morbidity if the baby survives if there is a severe meningitis. So as per Indian studies, we have got through the Delhi study, which was a Danish study, which was done in Delhi. It is a cohort study. It shows that there is a incidence of meningitis was varying from 0.3 to 3%. And the only way to rule out meningitis essentially in all these cases is by doing a lumbar puncture. Yeah, the published success rates for lumbar puncture is 50 to 60%. It was carried out from a journal that was conducted in 2008 by the UK people, and through that they have got this percentage of the number. And as far as we know, most scenarios where we are conducting lumbar puncture is especially in the late onset cases where it is mandatory to rule out. Or early onset sepsis cases, lumbar puncture is usually carried out with a high risk of suspicion. And why it has to be done? Because it helps us to determine the duration of antibiotics, whether it is a clinical, subclinical, or a suspicion or a frank evidence of a sepsis. That helps to determine the duration of antibiotics, whether for 14 or 21 days. So traditionally, it was once done by Quinique in 1991, where it was a very crude and a harsh method, where it was very painful, and then stylet needles were also not available during that time. Over the years, the technique has been improved, but the base is always the same. The foundation one was using a lateral decubitus position and late stylet removal. That late stylet removal is simply that we have to insert the needle until we reach the subarachnoid space, and then later on check if there is a clear CSF fluid coming or not. So previously, lateral decubitus position was determined because it was initially conducted in adults, stating that by having this position in a curved posture will help in increase the vertebral intervertebral distance so that the space can be easily accessed. So what happens if we needle gets advanced too far or too early? Also, we won't get a successful LP, but the risk is if we advance it too far into it, we have a high risk of a rupture, that is a giveaway, and it will lead to a bloodstained dam. So in this trial, what they want to practice or what they want to investigate or intervene is by introducing a sitting position and a early stylet removal. That is early stylet removal is by just inserting into the subcutaneous. Once we reach the subcutaneous tissue, by slowly guiding out the stylet, we will be guiding in the needle, and that is what it means by early stylet removal. Even though it is being practiced at very rare centers, but it is only being backed by observational evidence or the people who are well versed in practicing that technique. So nowadays there is a growing evidence for ultrasound assistance, especially in the adults, but in neonates there is a little few evidence to improvise or to assist how it will guide us in the future. So based on this hypothesis, they came to make sure that to reject that there is no principal difference between the sitting versus lying LP in association with the early stylet removal and the late stylet removal. So as sitting position is one when we held as in the semi-upright position, where the baby will be held by two arms, or you can place a pillow in front of the baby so that it will give us like a arch back support, like when we give in the posterior, the same in the anterior version, and it helps to increase the intervertebral space. That's how they are advocating that sitting position. And the early stylet removal is, as I mentioned, if once entering into the subcutaneous base, we just need to slowly guide out the stylet and introduce the needle further into the arachnoid space so that the chances of injuring or advancing further and injuring the venous plexus will be less. So for any RCTs, the consort statement has been used for the critical appraising. The RCT trial was also followed up and was based on this consort statement guidelines itself, which comprises of 25 questions, which we will be covering them in through this journal in the next.
Dr. Arjun, before going, shall we go have a poll session?
Yes, sir. Yeah, there will be a short poll. It's nothing like knowing or not. It just we want to know the senses of how it is. Sir will be sharing the poll, so please do attempt. Sir?
Is it able to share now?
Not visible, sir.
Yeah. Launching the poll. Is it visible now?
Yes, sir.
I have not shared the screen. Okay. I'm
Sir.
sharing. I'm sharing my screen. Huh?
Okay, sir.
Is it visible now?
Sir, you are sharing the other poll, sir, the previous one.
Previous one, first poll.
Yes.
Is it visible? Okay. Okay. Dr. Arjun, can you comment on this?
It's not visible, sir.
You're not. Okay. Your screen is not. My screen is not visible to you.
No, sir. The poll is not visible.
Okay. Around 29% have commented that the change in practice is recommended, and around 28% are telling it the conventional traditional method is better. Around 39% have not decided. So how would you?
Yeah, I think it's still under debatable. As we go through the article, we will get a lot of questions as once we go through it.
I'm sharing the results. I'm not sure whether you're able to see the results. Okay. Okay, fine. Okay, Arjun, I think I'm stopping sharing. Huh?
Yes, sir. Sir, you have to stop sharing. Yes,
yeah,
sir.
yeah. Is it okay? Is it okay?
1 second, sir.
In the meantime, by the time Dr. Arjun makes arrangements, can someone just come through what are the methods by which we can assert, like consort? What are other methods you know by which we can analyze RCT or systemic review, meta-analysis, or case control, cohort? So what are the other methods? Just it's not an exam. Just feel free. Maybe right or wrong, not a problem. So consult is one thing. Some other methods like can answer, unmute and answer. Yeah, I'm not muting anybody here. Arjun, you want to comment? Other methods like consult?
For each for systemic meta-analysis, we'll have Prisma method. But for our studies, we'll use the consort. For cohort studies, we will use the strobe. And so there are appraisals for each methodology or the studies what we are following. These are the common ones we use them.
So it was consult is around 2010. It's a little older version, but we are using the same thing. There are two terms like quorum and Prisma P for protocol. And this is it's combinedly used for systemic reviews and sometimes for RCTs also. And the strobe is also another statement. So it is just as guidelines by which we should know whether the article is rated correctly. Yeah, please.
So we'll be covering all these 25 sets of questions in this while we go through this journal. So the first questions are whether it was identified as randomized trial. Yes. The structure summary of the design details will be discussed further. Yes. Scientific background explanation of rationale. Yes. Specific objective or hypothesis. Yes. They have mentioned why they are conducting and the background, and also explained in detail why the need for having a protocol or a technique for institutionalized technique, same technique to be followed. So the sample size, they have used the regular statistic measures to have a 10% absolute difference from the studies which they have got through the proportion of successful LPs in one of their published studies in 2015, and with the statistical power of 90% and with a 5% of two-sided signal, that is outliers, and assuming a 5% of attrition bias, the required recruitment target is of 1020, which allows for at least 255 in each of the 4 groups. So the study design was a open label 2x2 full factorial randomized control trial. And along with that, they have conducted an internal pilot study, and it was done in 21 UK maternity and neonatal centers. So 2x2 factorial study is to determine, it is like randomizing two independent variables into two groups, that is two dependent variables as A and B, and further these two variables are still randomized into category C and D. That allows us to test two different hypotheses, that it is as similar as the success of LP in sitting was lying and position, which was further randomized into sitting position with early stellate removal and a sitting position with late stellate removal. Same goes for the lying position. So that is called 2x2 factorial. So what is that is the independent variables. So these are the independent variables, that's the success of outcomes. And the dependent variables include the sitting versus lying position with early stellate removal and late stellate removal. That will are the dependent variables that will help in finding out the outcomes. So when we are adopting two hypotheses and testing them both, which is better, so they usually adopt a 2x2 or sometimes 2x3, 3x3 factorial randomized trials. So what happens is when you plot the means of these variables, the results, if you have an intersection and a non-intersection, means if they are not intersecting, that means they have no effect on the outcome. That they do, whereas when they intersect, that means they do not affect independently, but when they do act, when you are mixed or combining those two variables, they have an effect on the outcome. So that will helps us when we plot these means of in the graph model. So the inclusion criteria was willing full consent of parents, taking with the corrected gestational ages of 27 plus 0 to 44 plus 0 weeks. And they have made sure a working weight of more than 1,000 grams and LP for the first time conducting the procedure as a current indication. And exclusion criteria is, if usually the exclusion criteria when they are unable to make sure they can't hold the babies in the sitting position, usually they included as intubated and mechanical ventilated, or they are hemodynamically unstable, or they are getting compromised like post-surgical or gastrocysis like that, or omphalocele, and if they are already randomized to the trial. Rest all the characteristics were they are already included. So the intervention was it was being compared between sitting and lying position. Along with that, they are still again randomized with early stellate removal and late stellate removal. So the clinicians who are undertaking this trial are usually not trained. So they made sure that whoever participating in this trial were received appropriate training through uh, pilot studies and different trial techniques and through online video sessions. And they were advised only to take 1 to 2 attempts, which they are described as one procedure. So one LP procedure is generally described as taking a single or a double attempt, not more than that. So their main outcome is to get the successful CSF, that is with no RBC or RBC with fewer than 10,000 millimeter cube in CSF within the first procedure attempt. That it might involve first attempt or a double attempt also, but it should be the first procedure itself. So the secondary outcomes, what happened is, as they included a lot of arms in this study, like 4 arms, and they have included a lot of factors. So they made sure that the secondary outcomes are characterized into 6 categories, like having the proportion of getting a clear CSF in these attempts of the lumbar puncture through all the 4 techniques. And they described what the clear CSF as the best one, followed with blood stain, and followed with the pure blood or a clotted one. and they made sure that even 1 to 3 drops of CSF is also being able to get under a microscopic evaluation, so that reporting of RBC count was done for each and every sample they have collected. So they wanted to make sure that by how many times the procedure was conducted and how many attempts was done, and the proportion of the infants were diagnosed with whatever the sample they have taken as meningitis, as WBC count as more, or there will be a positive in a culture wise or a polymerase chain reaction, and RBC count was adjusted. WBC count is adjusted for every 500 RBCs, one WBC for every 500 RBC to give a correct WBC count. And they labeled the CSF interpretations as meningitis, equivocal, negative, and uninterpretable based on the WBC counts and the culture and the PCR. And they have also recorded the time taken on first procedure from start to cleaning of skin to removing needle. And they have used the movement, infant movement during the procedural technique. And they have described this movement in a 4-point scale as no struggling, mild struggling, moderate, and severe struggling. That is based on from one of the studies which was conducted in 1993 from the role of local anesthesia during lumbar puncture in neonates, where they have made this more 4-point scale, Likert scale. So, and they have also tried to make sure the secondary outcomes include related to the cost and the safety. So the safety wise, cost wise, they are calculating the duration of the stay and the duration of requirement of antibiotics. And safety wise, they are concerned with the complications occurred during the procedure, especially the cardiovascular instability, desaturations, or escalation of a respiratory support. And for all these things, they have conducted initial pilot phase study, and which included a parental anxiety questionnaire, which was removed by the trial steering committee in this trial. They have only included into the pilot phase. So data collection wise, they were randomized in 1:4 ratios of equal proportions, as lying with the late stellate, sitting with the late stellate removal, lying position with early stellate removal, and sitting position with early stellate removal, using a web-based randomization. And they used a stratified block randomization to make sure that the population is homogeneous in all the subgroups of it. And they were done at the time of the trial entry itself. And they were trialed to assure the balance. They were, because of the long inclusion criteria which they included from 27 to 44, so they made sure that they divided it also into 4 groups as 4 blocks, and then they randomized again into 4 groups as 27, 32, 37 to 40, 41 plus weeks. And they made sure that if the same baby requires repeated LP, or if unsuccessful attempt, or later during that stay, if it requires another attempt of LP, they were allotted the same technique. And they were not randomized if they are having 1 or more conditions. They were continued in the same subgroup or whatever they were allotted. Multiple births like twin gestations or anything were randomized separately with their individual ID numbers, and they were linked for their data understanding purposes. They hired an independent statistician, a programmer, as well as a senior trials programmer to go through the data to get through the interim analysis. And it was all given to the data monitoring committee, even though data monitoring committee has no direct effect in the trial per se. So block randomization is by dividing a sample population into equal proportions. So they can be divided into equal proportions involving everything, so that the size of each group of study stays similar. So it includes all the gestational age characteristics, weight characteristics, gender characteristics, so that they make sure this block randomization helps us making the population heterogeneous. So how they stratified is they stratified why you have to stratify this block randomization is it helps in to make sure that the general baseline characteristics of all the data in each group remains the same, so that whatever the population of 100 in each group remains the same baseline characteristic, at least they are matchable or comparable. So it is like a nested model type. So total of 1020 with allocation ratio of 1:1 first LP, and with an intention to treat, so that the intervention what they wanted to plan is a successful one. So while conducting this study, as we know, it is highly impractical to blind the practitioner and the nursing staff. The only persons who were blinded is the persons who are analyzing the CSF sample. The parents were also blinded, but if they have requested, then the information was shared with them also. So this is the data schedule. Initially, after enrolling into the data, they were initially randomized, consent was taken, and the LP was done within the day itself. They were randomized, or when the consent has been given, it was not allowed to be delayed more than in a day, 24 hours, so that the allocation staff who has been allotted has to conduct the procedure immediately. So complications wise, they have seen the made a serious adverse events rules, which includes the iatrogenic meningitis or any complication during the procedure as spinal hematoma, development of hemorrhages, or any herniations or any damages or nerve damages were all considered as a serial adverse events while conducting this procedure. So the trial stoppage method, they have used the Hay-Bittel-Pito approach. It is a reasoning approach which is employed in most of the trials, which simply states that when the probability or the p value is less than 0.001, then it shows that the treatment group or the intervention what they've carried as a significant effect. Then there is no further need to carry the trial further onwards. You can stop the trial in between. But as such, they didn't made any formal statistical stopping rules. If so required, they would have made sure that they follow this approach, Hay-Bittel-Pito approach. So the pilot study, which they have used, 250 infants were randomized in all the centers over the duration of 8 months. And through this internal pilot study, they came to know that it is as a successful rate of getting a LP in the sitting procedure. And that's how they made this NeoCLEAR RCT trial. So analysis wise, they have, as mentioned earlier, they have divided into 4 groups as while randomized allocation of 1:1:1 of ratios. So they compared the groups with taking the lying position with the late stellate removal in, and early stellate removal was as a sitting position, including both the late stellate removal and early stellate removal as one analysis. And the second analysis, what they have done was the taking the late stellate removals groups into one with the early stellate removals in the other group, not depending on whether they are sitting or a lying position. But since we already know that lying position and late stellate removal are the traditional approach, they have been identified as a reference groups in comparing the outcomes in all the remaining 3 groups. So the analysis wise, what they did was, so for all the outcomes, what we have mentioned, primary, secondary outcomes, as it is a 2 into 2 factorial design with dichotomous outcomes, that's like yes or no or a pass or fail type. So in these studies, as exposure is now the outcome is what we are seeing, so risk ratios and confidence intervals will be usually employed. And they have used a log binomial regression and Poisson regression models, because these helps to understand the statistical significance of these groups that helps to determine the risk ratios, that is the adjusted risk ratios, by taking the means through these regression methods. And whereas for continuous outcomes, they have taken the linear regression models. So relative risk, as everyone knows, also known as risk ratio, is the incidence of disease in exposed by incidence of disease in exposed. So we want to see the outcomes with the risk factors, like what we are intervening is with the sitting versus lying, and the outcome is successful LP or not. So risk factors, the risk ratios are the best, as there are 4 groups being a nested model type. So we had to adjust, they have taken adjusted risk ratios by taking all the means of all the individual groups, and their statistical significance were done through, if the variable is a continuous variable, then they have done a linear regression, where it helps us to analyze the any variable that is in variation, that is if any dependent variable is in variation with the independent variable, then we usually apply a linear regression model. Whereas for nominal data like yes or no, where we have a dichotomous outcomes, that is 2 outcomes, and having only answers as yes or no, pass or fail, successful or unsuccessful, there they have applied the log binomial regression model. Whereas when they have a count like a number of attempts or the number of procedures or the number of cells or the number of time they have seen, they have taken the Poisson regression model. So the interaction, the secondary analysis also was done mainly. This is not for outcomes. This is the analysis methods, how they have approached from primary. First, they have seen for the outcomes for all, and the secondary analysis, what they have seen is they wanted to estimate, investigate whether the early stellate removal and late stellate removal will have a difference in the sitting or lying position for the primary outcome. And they have considered the position and timing as the main effects, and they have taken the likelihood ratio. Likelihood ratio is simply a hypothesis test that helps you to choose which is the best version that you try to adopt in adopting this LP procedure, like sitting with ESR or sitting with LSR or lying with LSR or lying with ESR. So usually likelihood ratios will be employed in these nested models, like 4 groups, that when we'll use this likelihood ratio. So then they have had a pre-specified subgroup analysis where they wanted to see what will be the consistency or differences in magnitude of different treatment in the procedure outcome among the different categories of the patients. So that's helping so they have analyzed in a subgroup analysis, which results will be discussed as we go forward. So the subgroup categories which they have done analysis was in the working weight, days of life which they have enrolled or randomized and the procedure undertaken, and the corrected gestational age at randomization. So they were total of 1082 infants, and they were randomized. The star symbol signifies the sitting group, as the plus symbol as the lying group, and the double plus as early stellate removal, whereas the delta sign for the late stellate removal. And out of these 1082 samples, there were around 6 were ruled out from the excluded from the study, even though there were a total of 13, but the remaining 7 people have been already included in the study. So their outcomes were included as a part of analysis, because they have made sure that it's a modified intention to treat, where they are looking for the outcomes. So the total sample of the study was of 1076. So baseline characteristics, as you can see, they have a very limited proportion of infants in the lower gestational age groups of 27 to 31 weeks. And the maximum working days group in which the day of life they were enrolled is within the first 3 days. So these include a higher proportion in all the groups. So it signifies most of the data is from the term groups, that is 299 and 187. And where are the rest of the characteristics are equally distributed in all the 4 groups. So they have also tried to analyze the what are the procedural pre-procedural methods, analgesia or sedation they required while conducting this procedure, whether they have enrolled in because of 21 centers, each one has a different practice. So whether they have used as a milk or a paracetamol or oral sucrose or pacifiers or topical local anesthetics or any anti-epileptics that were required for a sedation purpose in all these groups were also done. So as you can see, a lot of people have required a topical local anesthetic for the uh, sedation and the analgesia in this study. So funding wise, it was funded by the National Institute for Health Research. It was a part of their European department, UK, United Kingdom Department of Health and Social Care. But however, they did not play any role in study design or data collection or analysis and interpretation. So description of the trial design and allocation ratio, yes. Important changes to methods, we have no available data. Eligible criteria for participant, yes, they have mentioned. Settings and locations, yes. Whereas the sufficient details they are provided on how to interpret or analyze, yes. Pre-specified primary secondary outcomes and how and when they were assessed, yes. The sample size was determined, yes. They have made sure from one of the previous data they have got the percentage ratio taking a 90% power and 5% of statistical significance. And whether these applicable and interim analysis was done, yes. And topic guidelines, yes, they have made, but they didn't made any formal or particular protocol. Method used to random allocate, yes, they have used a stratified block and a serial web randomization. And details of any restriction, yes, they have made sure that 255 in each groups is there, but subgroups they haven't made anything. So mechanism to use to implement, yes, they have mentioned as how they are randomizing in each group and what are the gestational groups they have divided into 4 groups, and that's how they randomized. And concealment, yes, the parents were concealed, but the practitioners and others were not. Yeah, the next question includes the same. So blinding assessment interventions, participants were blind as neonates, it won't, but care providers were tried to blind as much as possible. Similarity of the interventions, yes. Statistical methods used to compare groups, yes, they mentioned. Analysis was also mentioned for the subgroup analysis as well as the basic comparison groups also. So the number of group participants were randomly assigned, yes, and losses and exclusions after randomizations together with reasons, yes, they are mentioned in their appendix, which I will be sharing at the end. Dates defining the periods of recruitment follow-up, yes. Why the trial ended was stopped? No, it was not stopped. Sorry for mentioning. Yes was mentioned as a part of whether they made a guideline or not. And a table showing baseline demographic characters, yes, they have shared the baseline characteristics. Number of participants in each groups, yes, they have mentioned. And the outcomes for each comparison groups, yes, they have mentioned and made as a 95% confidence interval, yes. So post-hoc analysis will involve the analysis after the events, that is after the collection of the data and performing the statistical sets, whether it is valid or not. Yes, they have conducted that. So the results wise, total of 1,079 infants had a first lumbar puncture, and out of and 166 had a second lumbar puncture. 6 in total were totally excluded, leaving 1,076 for an analysis. And what is the surprising part is at the time of trial entry in all the groups, it comprises totally of 961, which were termed by corrected gestational age, and they were younger than 3 days. So the majority of the population in this 1076 was the term group of babies, and they are younger by 3 days in life. So based on this population group, what they have made the outcome was the successful first lumbar puncture was achieved in the sitting group compared with a lying lateral position group, with a absolute risk difference of 6.1% with a adjusted risk ratio of 1 more than 1 to 10. So p-value is also significant. So what it means to say that the intervention, what they have taken or a hypothesis or what they have done is telling that sitting position has a higher advantage than lying lateral position. So these are the results. As you can see, the adjusted risk ratio in both the groups, sitting and lying group, the p-value is of 0.29. We'll come back to the early and late stellate removal. That is the second principal comparison, what they have done. The outcome observed was of not significant, nor it doesn't show any valid advantage whether you have remove the stellate early or you remove the stellate late. There was no such evidence in this group per se in this study. So this is the secondary comparison point, and but one thing what they've seen is in sitting position, by holding them in hands, what they found out the sitting position were less likely to show very little struggle during the procedural time. And so as you can see, the CSF obtained and during the first LP procedure, and the primary interaction outcomes, you can see the percentage in sitting ESR was high compared to the lying and other ESRs. So the first LP procedure means whether they have taken 1 attempt or 2 attempts, that was not mentioned properly in this study, and that was lacking. And they have themselves have mentioned that they haven't analyzed for those outcomes for first attempt and second attempt. So during this procedure, another thing they've observed is sitting was associated with fewer desaturations than during the lying lateral positions. As you can see, 93% to 90%, it was a minor. And the lowest oxygen saturations what went through in the sitting position was up to less than 80%, was of comprising of 35 infants in a total of 532. Whereas in lying position, it included of 72. So a little higher number was observed in the lying position. But when you take the means and the statistical wise, it was only of 3%. So they have made a forest plot for the subgroup analysis of the primary outcome. What only they have seen is the subgroup of infants aged more than 3 days old had a lower gestational birth, which was favoring the lying position. So this group of subject of infants, when they had a post hoc analysis, they found that this group of infants were usually had a lower gestational age at birth and a lower birth weight, as most of the study participants included a corrected gestational age. So when they gone back and seen the data through why this part of the group is on the favoring lying position, so the result was of lower gestational age at birth and lower birth weight. Whereas when you can see the rest of these characteristics were in the favoring the sitting position, but when you statistically signify, most of them are crossing the odds ratio of 1, that is the risk ratio of 1. The confidence interval arms are crossing this, so there was no statistical difference between these two positions. And few groups of these studies has shown that the sample size is accurate, and this determines the sample size, the blocks, and this diamond represents the overall analysis of all these subgroups. So it is also touching. So you can see, so it determines that it is an insignificant relation. So it doesn't prove whether lying position or sitting position favors in the LP. So similarly for the other characteristics also, they have done the same. That is the timing of the stylet removal. This is that has no significance at all, as all of them are crossing this central midline, the statistic significance. So it means that it neither favors a stylet removal or early stylet removal, or you can interpret as it has no outcome difference whether you approach through late stylet removal or early stylet removal in the timing wise.
Dr. Arjun, do you want to discuss more about the forest plot?
Yes, sir. So the forest plot is usually applied for multiple analysis in systemic and meta-analysis studies, mainly for comparing the multiple studies on a single subject which they want to analyze, and they want to collect all the data from individual studies, and then they compile them and see the statistical significance of each study, and then they plot. So the either side of this line will determine what you want, either it favors or not favors, or if it has a occurrence of a disease or not occurrence of a disease, or has a higher chance or lower chance. That depends on how you determine these sides of the significant line. Whereas now the individual studies will be plotted on the left side as alphabetical order or the chronological order in the year they published. And each study population will be determined by the blocks. This black box will be the population size, and the more bigger the block size will indicate the size of the sample, and the population how much it is homogeneous. Whereas the arms determine the confidence interval, that means how much they are correlating with the variables among themselves. The longer the arms, that means they are very poor, and the shorter the arms, it determines the sample size is well homogeneous. So the longer the arms are is not a good one. And if the individual studies are on either completely one side without intersecting this midline, that means the studies are significant. Whereas if they are intersecting this midline, that means the statistical significance is lost and the null hypothesis is true, or whatever they want to prove out is nothing, and it doesn't have any effect on the population that they want to see. So if it comes on whatever side it may be, it never should touch the midline, that is the one. So as everyone knows, the risk ratios, if it is equal to 1, it has equal effect on both the numerator and the denominator. Whereas if it is less than 1, it has a higher ratio on the denominator. More than 1, it determines the effect is more on the numerator. That is whatever the outcome or the exposure or the whatever the outcome or the disease per se, or whatever the factor you want to determine. And overall analysis of all these subgroups will be determined in this diamond that represents the entire analysis of these whatever the analysis of these subgroups were done. If it touches the line, that means the entire meta-analysis or the subgroup analysis itself is insignificant. So it is called as a forest plot.
It's beautifully described. I'll just add 1 or 2 points. The size of the box you will explain is based upon the sample size. And one more factor, because it's a single study, sometimes the statistical power is also taken into consideration. So sample size and the statistical power determines the size of the box. And when the line of no effect is touched by the diamond, then as per your discussion, whenever we put a forest plot, there are 3 things you should see: whether the heterogeneity is there or not, and the number effect. Number 2 is the pooled results. That is, in this case, it is not possible. Sometimes we want to see multiple studies the same outcome. In this case, it's a subgroup analysis. But if I have a pooled analysis that all the data is combined to a big Excel sheet and try to put it single, that is called pooled effect. And last thing is the publication bias. Sometimes this is only one thing that is not practically possible. One of the disadvantages of forest plot is sometimes they miss the publication bias, because only successful results are published. Unsuccessful results are languages which is not routinely read by the public or not taken into consideration. So publication bias is one thing which is not answerable in a forest plot. Apart from that, heterogeneity we can diagnose, and pooled data also is diagnosed. But this is not a routine forest plot. But you have beautifully explained everything. It's a subgroup analysis of the first plot. Yeah.
So adherence to the locator techniques, there was a lot of inadherence in the sitting room because the clinicians were in themselves were in the initial attempt to learn this, practice the procedure. So there was a lot of inadherence in the sitting group. They themselves mentioned, and sometimes the clinicians itself have determined it is better to do it in the conventional lying position. That's why there is a higher number in the sitting group. There were a total of 4 subjects having a cardiorespiratory deterioration, and that is 3 of them in the first lumbar procedure and 1 of them in the second lumbar procedure. And among them, 3 subjects were requiring a early respiratory support in the 1 in the sitting group and 2 in the lying group, and that doesn't carry much significance. So 4 serious adverse events were reported, and out of which only 3 were not related to lumbar puncture. 1 was related to scrotal hematoma, and they have attributed it to the improper technique of placing the needle. So binary outcomes, yes, they have mentioned and how they were analyzed, dichotomous outcomes. Other analysis, yes, they have made a subgroup analysis, and but they have made a forest plot diagram of it. Serious adverse events, everything were mentioned. And limitations wise, as you can see, they have included a lot of term babies and younger than 3 days for the population, and very little data is available in for the study subjects less than 27 weeks, and they have not included on 1000 grams. And the secondary analysis, they haven't done for a lot of other risk factors, like what are the type of respiratory support, what are the characteristics of the babies at the time of the sepsis or the clinical sepsis, and what about the interpretations of the WBC count, even if they were negative, and how the clinical hemodynamic status of the baby, all these were not mentioned. And especially the respiratory supports, if it is a high risk case or an extreme preterm, they haven't included in this study, nor they haven't mentioned how this sitting position will be favorable in very low birth weight babies or babies on the ventilatory support. So trial limitations, yes, they have mentioned partially. And generalizability, yes, we can apply for all the term babies as of now for this trial basis. Interpretation wise, yes, we other relevant evidence they have provided as per their previous data itself. Registration number, everything was done. Trial access, yes, they have provided full free access to the trial. The remaining articles will be shared in the group. Funding, yes, they are mentioned, and they have no role in the study per se. So conclusion wise, this is the largest trial per se, the first trial to conduct and to protocolize this lumbar puncture, and the optimal technique is still debatable, as you can see in the poll, and minimal data is available on preterms and those especially on the ventilatory support. So this is the article, and thank you for your patience.
Thank you, Dr. Arjun, for the excellent elaboration. And we can receive questions. Dr. Arjun, we have received one question. Any mechanism by which this scrotal hematoma were you able to go through the things, the mechanism by scrotal hematoma?
What they have mentioned is mainly because of the advancement of the needle, especially by the trained, not so well trained clinical practitioner, because they were also in the learning techniques where they have punctured the venous plexus repeatedly, and it lead to the collection gravity based into the scrotal thing. So they tried to rule out all other causes of why the baby had developed, but they didn't mention in detail the time duration or the lapse duration after the procedure when the baby had developed, or how the mechanism they were also unable to explain. They just ruled out by the remaining causes. They have ruled out all the other remaining causes, and that's how they came to the conclusion that LP was leading to the scrotal hematoma in that single alone baby in the entire study. But as if you go through the literature wise, there was only thing.
We received one question. The person who did the LP documentation.
They have just mentioned they are the consultants who are there, but they who are participating in the trial, and they have trained their residents, but they haven't mentioned the years of experience or the working exposure or anything in the procedure. Whoever is available in the 21 data centers, they have utilized them, but they didn't ask what is their level of graduation or what is the level of experience in conducting those procedures. They didn't mention anything on those.
Any other questions? Thank you, Dr. Arjun, for the excellent presentation. Thank you, EN team, for organizing the meeting. There are no questions. I would appreciate it that we'll call the session.